at the first session, Dr. Rashan Haniffa. Dr. Rashan Haniffa is a research physician attached to the Central Tropical Medicine Unit of Oxford and Manitoba, Oxford Tropical Medicine Research Unit, Bangkok, Thailand. He is the project coordinator of the National Intensive Care Surveillance conducted by the Ministry of Health, Sri Lanka. He works as a specialist registrar in anesthesia and intensive care in London, UK. And he will talk on a case study presentation on workplace-based research. Dr. Haniffa.
Thank you, Chairperson, sir. Good morning, everyone, ladies and gentlemen. It's my pleasure to speak today, and as Dr. Padini mentioned, thank you to the SLMA for having the session and for the organizers for inviting me to speak. I have a few affiliations which I have put on the screen here as the Chairperson Search kindly introduced me. Perhaps the person who should be doing this presentation is perhaps Dr. Pubududi Silva, who I'm sure you all know, but because I work for another overseas university, I'm probably speaking on his behalf, but I think most of the work and the gratitude should go to him. So here we go. So we're going to talk about workplace-based research, and what I'm trying to do, hopefully, is to follow what Dr. Padini has started by trying to say, okay, what is the role of workplace-based research and how can that be performed? And my role is probably to highlight two case studies of how we have facilitated workplace-based research in this country. Okay, this is slightly different to what you might hear in a session like this, where people might come and say how they propose to do things. So we are in a slightly fortunate situation here, because we are going to say actually how we have managed to do this. And the first thing I think is to probably understand and accept that this kind of thing is impossible without a collaboration. And you'll see through the theme of this talk that it is a theme of collaboration. A collaboration which involves different people, depending on the project involved, depending on the need and depending on the capabilities. We have collaborated widely, and we are fortunate to come and present this. Some of the data we are going to present here is actually being presented for the very first time, and I hope you find it interesting and revealing. So the two case studies, one is a national level case study, which we like to call a national cardiac arrest study. Okay, so why have we done that? Because cardiac arrest, we all know, very dangerous. Cardiac arrest outcomes are really bad, internationally bad, pretty horrible outcomes actually. If you're lucky, if you're in the best centers, you might have 30% survival home with intact neurology, if you're lucky. Okay, if you're unlucky, you probably have much worse. And there's enough studies to tell that mortality and outcomes are really horrible. However, we know that cardiac arrest is a preventable condition, quite often, not always of course, but quite often it is preventable. There are signs that the cardiac arrest is coming, and it's important to detect those and try and intervene. And people who have succeeded, because cardiac arrest is very bad and difficult to treat and involves a lot of expenses and outcomes are poor, it's very important to try and prevent them. Okay, and people who have succeeded internationally are the people who have prevented cardiac arrest or prevented the deterioration and intervene. And we'll talk a little bit about how we have led from the first case study to the second one. So why have we done this? Because we really don't know outcomes of cardiac arrest in this country. We don't know what equipment facilities are available, and that's also directly related to cardiac arrest. And we don't know how much or how little training has been done for doctors and nurses in terms of resuscitation and CPR training. So what we've tried to do is, as I said, a collaboration. And you can see the partners there, and I hope I haven't forgotten anyone. And if I have, it is not intentional, but it is a very wide collaboration. And you will see from the following slides why such a wide collaboration is needed and why the Ministry of Health has to take the lead in this kind of thing and how the others have to facilitate. Because indeed the service improvement, like Dr. Padini mentioned, about quality of the service, about the productivity, about improving patient outcomes, about the training of the staff, should indeed be the primary responsibility of the Ministry of Health. And hopefully this is one step to move that forward. Okay, and we also collaborated with the GMOA, the Faculty of Medicine, and the National Intensive Care Surveillance. So what have we tried to do? We've tried to understand what are the number of basic cardiac arrests, how many people die in hospital, because sometimes in this country it's a bit difficult to classify whether it is a cardiac arrest or whether it's a death. I know that might sound a bit pedantic, but that's important because cardiac arrest is something where people recognize as an intervention they want to do to try and prevent or treat that cardiac arrest. Whereas sometimes they may say, okay, this is a natural expected death and we are not going to intervene. So we try to count the two things. Thereafter, we try to say, okay, how many people were resuscitated and indeed how many then survived, because that's important for us to know. That's not enough by itself because we also need to find out about equipment, because a hospital which has good facilities, a ward which has trained staff, a ward which has good equipment is very different from a ward which doesn't have that. And I'll show you some data to perhaps understand how that may vary. And I hope you will be stimulated by what you see about those numbers, as I was surprised by some of them, which we will try and show. So it's a little form to say what we have done. So it's a daily data collection sheet, and I'll try and describe how we did this. So this is a daily sheet which we collected for 1 week from pretty much every ward above base hospital level in this country. Okay, so for 1 week, we continuously gathered from each ward about deaths, attempted resuscitation, successes, and use of equipment. So I'll describe how we've done that. Then I'm just going to show a couple of other forms which describe what equipment was available on the ward, okay, as a snapshot. So this we collected only once. I hope you can now see the connection to what Dr. Padini was describing about workplace-based research, how we are trying to look at patient outcomes. We are trying to look at the facilities, we are trying to look at the service, and we are trying to look at training and how that can be improved. Okay, and you can see some of the equipment we've looked at, and this is only one part of the form. Whether trolley is available, whether there is a defibrillator available, whether there is an ambu bag, whether there is an ET tube, things like that, which people might take for granted, of course. And I'll show you why it may not be a good idea to take it for granted from some of the data we have. Having talked about equipment, it's important to talk about training. And what's the use of equipment if you don't have trained staff? So how well or how badly are staff trained in basic life support, advanced life support, pediatric life support if they're looking after children, and whether that's for doctors or for nurses? Because if there is a problem in our outcomes, one of the obvious ways to intervene, you would have thought, would be to institute better training. So data collection was a massive task, island-wide data collection for 1 week. I don't know how many of you might have even been aware. We've had to do this gently without agitating people, but with the collaboration of all the stakeholders involved. Okay, the GMOA collaborated very actively. The Ministry of Health led the collaboration. We trained the data collectors, and I will show you. So that's some of the data collectors who came for training. So we gathered them in groups, provided them information and training as to how to collect the data. There were no funds to pay them, of course, so we have to rely on the goodwill of people. It's not possible. We didn't have funding for this kind of study, but it was important to do. So with the goodwill of doctors and nurses and directors around the country, we managed to get them in groups, train them, give them the data sheets, and then coordinated this centrally by a group of about 10 people. And I'll show you some of the methods we used to coordinate. And these are some of the pre-interns. Dr. Padini may recognize some of those people as GMOA pre-interns as well. And they worked with us while we did this, based in a room at the National Hospital. About 10 people, and you may understand why we do that. And what have we given these people in return? Well, we thought we'd give them a certificate saying that they collected data for us as data gatherers and collaborators. And also when we publish this information, we will acknowledge each of these people by name, okay, as people who have contributed to what we hope is important workplace-based research in this country, which will directly contribute to improved patient outcomes. So on a daily basis, we gathered this data. So pretty much every ward, ETU, labor room, pretty much everywhere. And we used electronic methods of gathering the data. So where have we done this? In 92 hospitals, in 1,350 units around the country. And the number of patient stay days we've covered is nearly 200,000 in that week. Okay. So that's just a little breakdown of the type of hospitals, whether it's base hospital, teaching hospital, district general, and so on. And also about the hospitals in the different provinces, where we tried to capture pretty much every hospital. And unfortunately, there were a couple of hospitals who didn't want to participate, I'm sure you won't be surprised about that. They kind of said, we are not interested in this. But the vast majority of people, and 92 hospitals, wanted to, and they were quite willing to and were very helpful. So that's data return, actually. Apologies for the typo there. So I'm going to try and show you the number of forms we've got back. So what I call by daily cardiac arrest forms, this is not to try and bomb you with data, but to try and show how we may coordinate workplace-based research on a national scale and do it without spending large amounts of money, but using the goodwill of people for something which is important. So in each type of hospital, we calculated how many forms we may need and what we received. And I'll just draw your attention to this number here. So we thought we'll end up needing 10,600 forms. We managed to get 9,600 back. I think that's quite an achievement for a group of people sitting centrally coordinating this process. And the same with regard to equipment, adult equipment and pediatric equipment. We are working on getting some of these back. And you can see the training, the doctors and nurses, we had to modify our data collection techniques slightly, and we had to change the form a little bit. So we are gathering this data. We are hopeful that will come to about 80%. So if there's anyone here who belongs to these places, who haven't sent us the data and wish to contribute, then you are welcome. We don't gather this data anymore because we've stopped, but the training data is possible to gather. So I want to just show you what we use to collect this. This is an electronic dashboard, Google Forms. But you saw the group of people who gathered the data and coordinated it. So they basically used this dashboard on a daily basis to see which forms we got and which we didn't. And when we didn't, we just contacted people and asked them to send stuff. And you will see that the dashboard nicely filled up. Okay, and we managed to do this virtually paperless. So what did we find? Okay, I'm just going to show you a few snippets of data. I'm not going to show all the results, but I'm just going to show a few snippets just so you understand what we may have. So there were 631 total inpatient deaths. So as a marker, how do I know whether this is an accurate reflection of our hospital deaths? So we looked at the annual health bulletin, 2012, the last numbers which are available. There are about 700 deaths island-wide in hospitals. Okay, 700. So I think 631 is an accurate reflection of what goes on in this hospital. Remember, we didn't cover all hospitals. There were some which we didn't. So I suspect that's a reasonably accurate reflection. Attempted resuscitation. So these are the resuscitations which staff thought they attempted. Okay, they basically did CPR, chest compressions, ventilation. They may have defibrillated. And how many were successful? This is successful at the point of resuscitation. Okay, this is not discharge, this is not ward discharge, this is not ICU discharge, this is not discharge home. This is successful at the point of resuscitation. 114. Okay, if you think about it internationally, that's not too bad. Okay, it is reasonably in that kind of ballpark. But if you look a little further, there are some things which are a bit disturbing. So I'll come to that other slide in a second. If you look at these, so these are the survivors. We managed to track down 114 people as possible survivors who had been resuscitated successfully. There were deaths 50. What are these deaths? These are not deaths at resuscitation. These are deaths in hospital. Okay. So they either died in the ward after resuscitation or they died in the ICU after resuscitation. And we have that breakdown. Okay, we know where they died. So 38 people discharged home out of, you saw, some 600 number. Okay. We excluded 12 people basically because they were babies. Okay, we weren't looking at babies. They had gotten into the form, so we kind of excluded them. It was difficult to exclude at data collection, so we excluded at analysis. And we didn't have contact details for 14 people. So out of 114, we only didn't have contact details for 14. We managed to track them all down. Then we followed them. We followed them for 30 days, and we followed them for 6 months. And you can see what's happened to them. 38, 30, 25. So 6 months later, 600 cardiac arrests later, we have 25 patients left. Okay, I'll let you draw your own conclusions about what you think about that. So, why am I showing this? Because we are doing quality of life follow-up for these patients, okay? So we have some information about how good their quality of life is, because as you will all understand, there's no point being resuscitated from a cardiac arrest if you then can't do any of your activities of daily living. And we are following these patients up, and we hope to follow them up for a year. So obviously we've got ethics for these things, and we are doing this in a transparent way. So just going back to equipment. So I'm sorry, the slide is a bit busy and it's a bit small, so forgive me for that. This is defibrillator, that's emergency trolley, that's an ambu bag, ET tube, capnograph. Okay, capnograph, for some of you who may not know what that is, it's an end-tidal carbon dioxide detector. Okay, it's the best way of detecting whether someone's been intubated well. I'm sorry if that's already well known. So defibrillator, just going to show you some totals. Okay, so if you look at these numbers, that's about half the wards have a defibrillator. Even ambu bags, less than half the wards seem to have an ambu bag. Okay, so this is what people said they had. Okay, and we collected this. So I'm sure this involves a mix of wards. Okay, acute wards, not so acute wards, and so on. And ET tubes and capnographs, and we will obviously give this information to the ministry and see what they want to do with that. Okay, so why have we done all this? Because we think it's important to reduce deaths due to cardiac arrest. However, before you try to reduce those deaths, we have to stop people having these cardiac arrests as much as we can. Because cardiac arrests are expensive, and as you have seen today, outcomes are not very good. Okay, they're pretty bad. And then we have to improve the equipment we have, and therefore also the training. And if you noticed, even the patients who were resuscitated after cardiac arrest, about 50 died in hospital. Okay, so what that suggests is we need to improve post-cardiac arrest care. And people who have done advanced life support courses will know there's something called a chain of survival. Okay, I'm sorry, I don't have a slide to illustrate that, but the chain of survival is basically early recognition and prevention of cardiac arrest, early CPR, early defibrillation, and post-cardiac arrest treatment. And you can see all four of those, we are in need of improvement. Okay, and I would argue that we probably should invest the most in preventing cardiac arrest as opposed to treating. Okay, I'm not saying not to treat, but I'm saying we should probably invest more resources. So we do some training, which is kind of what led us to do this work. And these are all the collaborators involved in the training, and there are some who I haven't mentioned. Apologies to those people. But again, it's a national big collaboration involving lots of groups. And that's kind of the people, the distribution of people we have trained. We actively gather this data. I hope that's an illustration of not sticking to one area and not focusing on one province, but rather trying to distribute the training and make it available to people in a progressive way where people can access it, okay? Even close to themselves, because we go away to do the training, and I'll talk about that in a second. So we use simulation, we use scenario-based training, and these are some photographs, examples of some of the work we do, and they are used mostly using borrowed equipment, equipment which has been donated to us, using space which we sometimes ask nicely, sometimes which people give us, okay? And that's some simulation training. So we basically can have a mobile ICU, we can have a ward setting where we can do scenario-based training, and that's very popular and goes very well actually. And we can do it for very little money. We're very proud because we have a group of people who can institute this training in collaboration with the doctors, the nurses, and the ministry. And you know, I don't know, people have gone abroad, might have seen simulation centers. This is our simulation center, except it moves. Okay, it doesn't stay in one place. It's in boxes. And if you want a simulation center here, in an hour or so, we can have one, okay? But the simulation center, as people will understand, is more about the people who do the simulation and not about the equipment. The equipment, pretty much anyone can get. So these are our Moodle page of all the pre-course material. Why am I showing this? Because now if we want to improve outcomes from the workplace-based research we have done, how are we going to improve outcomes for doctors, nurses, training, and so on? And that's kind of the material we use. And these are courses which people can click on, log in, and use pre-course material before they come for our courses. So the training we do with the GMOA, with the ministry, with the Faculty of Medicine is a whole range. So we have the ICU skills training, which we've trained nearly 1,000 people now. I'm very proud, doctors and nurses. Okay, we train them. The cost and Dr. Padini mentioned cost. We calculate the cost. I don't know, I'll let you decide whether it's cost effective or not. By our calculation, our training per head costs about $12. Okay, we've calculated how much that is. It's about $12 is what it costs to do this training. It just means, I think, if you take care about what you do and work with the people and collaborate and work with the goodwill of people, I think it's possible. You don't need to spend massive amounts of money. And like I said, we haven't really bought any equipment. We basically borrowed and asked people nicely, and they've lent us. So what do we want to do? Basically work on preventing and managing cardiac arrest. I hope the SLMA, the GMOA, the ministry will now work with us to try and institute some of the lessons we have learned from the workplace-based research we have done. And that involves also training for doctors and nurses using simulation and scenario-based training. I just want to show you, without being too boastful, these are our training calendar, and that's for last month. You see these dates, they're all full of training. This is work we do with different groups of people, and which we institute in different locations. And we have a group of people, we can do this, okay? So that's our collaboration with the training. I'm not going to bore you with that a little. So having done the cardiac arrest study, understood that this is a problem, we now want to try and see whether it is possible to detect and prevent deterioration. You may argue it's not possible in this country. You may say there's nothing we can do. You may say it won't work. And I agree. We have to find out. And that's part of doing workplace-based research. You spot a problem, you generate a possible solution, and then you test it. And you hopefully have the humility to accept that sometimes your solution won't work. Then you understand why it didn't work and maybe refine your solution to improve it. And that's kind of what we want to do. So we've tried to say, okay, can you have an early warning score to detect patients who are at risk of deterioration? And then if these patients are detected, can we then train doctors and nurses to deal with them sooner so that they don't have a cardiac arrest? Is this possible? So another long list of people who we are collaborating with, okay? Again, to institute this, to test whether this early warning score led training would work. So we have started testing this in a district general hospital far away from Colombo. Why are we doing it there? Because those people want us to come and work with them. They want us to train the doctors and nurses. They have a lovely director, they have a very good matron, and they have lovely consultants. They want us to come and help them. Okay, I'm not going to name the place for reasons I will demonstrate in a second. So it is a district general hospital, and we do this with in-ward patients. So we have now about 1,500 patients where we have collected daily physiological observations to see whether we can predict cardiac arrest for those patients. Because if we can, then we can institute an intervention. But to predict that, can we see how many people have observations? And I want you to look at these red figures. So only that many patients have blood pressure measured on the ward daily. And these are heart rates. Okay, this is saturation. Forgive me if some of the numbers are wrong, but these are what is being measured and known on the ward clinically. This is not for data collection.